Thanks for chairing this session, Dr. Tirumali Sami sir and Dr. Suvanam. I would like to invite Dr. Vaibhav to moderate this panel discussion. The panel members are Dr. Rajkumar sir from Ganga Hospital, Dr. Arun Kannan, Chennai, Dr. Mukesh Mogan, Dr. Mohanty and Dr. Harish Bande. Sir, please join the panel. So we are running short of time, around 15 minutes. We'll keep bit short and crisp with the pertain to the points. So, Dr. Vaibhav, over to you. Thank you.
Yeah, thank you. So we had a very wonderful session last session. We had both evidence and eminence, and we've got a lot of eminent faculty here. It's my pleasure to welcome all the panelists, Dr. Rajkumar, Dr. Arun Kannan, Dr. Mukesh Mohan, Dr. Mohanty, and Dr. Bende. Welcome. As Dr. Yuvraj said, we'll keep it short and sweet, a term that I borrowed from the last lecture. Okay. So we'll have 4 cases only. And the first one will be about decision making. The second will be execution on the medial side, lateral side, and managing complications. So we hit the ground running, and I would go one by one. So after suitable conservative trial of symptomatic 55-year-old female patient, what surgery will you use? Dr. Mohan, you'll go for uni here.
Is it a correctable varus deformity?
Yes, it's correctable.
Right. So if you are confirmed with this an anteromedial OA and the patient wants to have a very active lifestyle, then I would consider uni also. And I would confirm with valgus stress X-rays and also Rosenberg view to identify whether involvement of posteromedial condyle is involved or not, and lateral view. And then I would choose a fixed bearing implant and with the robotic assistant. And what are the common questions they will ask me? Probably they will ask whether we can sit in the floor or how long it is going to last. Then I would say like probably around 15 to 20 years if the alignment is correct. And I would ensure that the opposite knee is also corrected in due course of time. And I would ensure that they should maintain their bone quality to prevent any tibial subsidence.
Okay, well said, sir. Dr. Bende. Will you do uni for this one? Any doubts, or you can advise?
Actually, I don't do many unis. I do most 99% is knee replacement.
Okay.
We don't have much time, but see the previous few lectures which were shown, they mentioned that the complication of uni at any time of age or at any time of chronological outcome is double that of TKR. And that comes out even from Dr. Vijay Bose's experience of uni on Indian patient with a Caucasian-based implants, that he was using 20% uni when he started, now it is 4 or 5%. So basically you have got a much higher risk of complication, and uni, if fails, straight away it goes to revision component many times, because you need to have augment, sometime a sleeve and a stem. So it's not a uni and then TKR and then revision.
Okay, so a short question. Which cases will you do uni?
Very rarely, very rarely.
Not even one?
Yeah.
Okay. Dr. Mohanty, which cases do you do uni? Objectively.
Yeah, means in this particular case, again, I am not a great fan of uni. Rather, I would prefer a CR type of total knee implant here in this particular case.
Arun, what's your indication of uni?
I would consider a uni in this. A few more things to look at. One would be BMI. Secondly, make sure there is no clinically, it's not an inflammatory kind of picture. Third would be to get a scanogram to look at the overall alignment. Those are 3 things that I would additionally look at before deciding on uni, apart from more X-rays, of course, lateral view and valgus stress view if needed.
PS?
No, with this X-ray, the decision making for a uni should not be done at all. First point. First is the most classical bone on bone is not there here. So that is what this will worry me. 55-year-old painful patient, already arthritis, even the lateral side overhanging arthritis are there. Skyline is important. So bone on bone is not there. You have to be little careful. Then go for other X-rays, lat stress views, and then take a call.
Okay. So this one has all the X-rays. Well said. You're happy with these X-rays? You want something more?
Can you go back to the scanogram also?
No, this is not. This is a different patient. This is a different patient now. So we are coming to the execution part of it. So the people who do uni, this is question for this. Are you happy here? We'll get a scanogram also. Apart from this, anything else you want?
There is some trochlear changes, so I would look at it intraoperatively. All X-rays said and done, whenever you go for a uni, I always keep a total knee backed up. So if I find anything that is, severe changes on the patellofemoral or any bone exposure on the lateral side, then we should be ready to switch to a uni during the surgery.
Okay.
So that
So
is
the
something
uni guys agree that this can be done as a uni case. The three of you who are uni fans.
Yep.
Okay. So question to you: any further workup? This is the scanogram. No trick questions. Straightforward.
It looks fairly.
So do you routinely get an RA test? Or do you routinely get an MRI done?
No, definitely not. MRI is, I think most people wouldn't get an MRI done. If there is clinical suspicion, CRP, more than RA factor, I would be interested in getting a CRP done more than the RA factor if there is
So
any inflammation.
CRP is routine for you. For you?
Yeah, MRI is not needed, but definitely not needed if at all a doubt. But mostly, if you are a doubt, then better not to do a uni.
Perfect. So no MRI. Anyone who does MRI routinely? Anyone who does RA routinely? No. Anyone who does CRP routinely for all our patients? So we should do CRP for all our patients.
But having said that, RA, whether we do it or not, if the radiological feature suggests of inflammatory condition, even a doubtful, better not to do a uni.
Okay. But if it's not suggesting, there's no routine
No, not
precedence
needed,
for
not
it. Okay. So if you see a patellofemoral changes, we had discussed this question: grade 1, grade 2, grade 3, grade 4. Contraindicated for anyone? If 1 or 2, grade 1, grade 2 patellofemoral, no symptoms. Clinically, no symptoms on X-ray 1 or 2 grade.
Grade 2, even grade 3 on the medial side is fine. If there is grade 3 or 4 changes on the lateral side, no.
Dr. Mohanty, would you?
Yeah, if not symptomatic, then doesn't matter. And as Arun told that if the lateral, facet patellofemoral arthritis,
You will not
then
do.
I will not.
The skyline matters. If there is any tilt or a small sort of subluxation or a tilt or pull on one side, better not to do that.
So the consensus is that if there are changes on the lateral side or a tilt, we should not do. Any contrarian views? No. Okay. So that's sorted. BMI cutoff. Anyone? Any cutoff on BMI?
I generally don't do it above 40.
40. Okay.
But actually, obesity is not a contraindication. We can, provided the patient fits into the other criteria, no problem.
Yeah, I think, So, high BMI with residual varus, with osteoporosis, all these factors lead on to osteoporosis. So, it's generally a combination of factors, not obesity in isolation, but generally people, BMI over 40, I avoid.
In this kind of situation, the physiological all matters, physiological activity level, patient, how good is the patient mobilizing. So then all matters, comorbidities. So it is not a single decision of obesity. Combination matters.
Yeah, Dr. Mohanty?
I have a question for other panelists. Do you consider the size of the bone while doing any uni? This has not been discussed. I have just kept in mind. Do you consider the size of the bone as a criteria to decide whether the uni or total knees? No, many times short-statured Indian females who come for knee replacement.
Yeah, we just had Dr. Bose say about that. So anyone just looks at the size. So if you go back at the X-rays, if you look at the size and you feel it too small for uni, is that something that comes to your mind when you look at the X-rays? Too small for uni.
Not,
After Dr. Vijay Bose's lecture, maybe yes.
Yeah, very difficult to say on X-ray alone. Again, it is a combination of factors. Small size, again, with obesity, with malalignment, higher chance for failure.
To make it very critical, in a small size female, if you are doing an Oxford, then the size becomes a big problem. Oxford sizes, particularly in the tibial side, for a female patient, it is a very, very critical. You will have an overhanging. So that is the problem. If that is a situation, better to do a TKR.
Okay. Is age a cutoff for anyone here? Or any age? Any age, young, old?
Old age better.
Old age better. Young age?
Yeah, he has to match the all other criteria, bone on bone. And,
criteria matching, but there's no age cutoff.
No age cutoff, no.
For everyone. So again, one of the consensus that we have here is that the age is not cut off. Maybe for some people, uni is the surgery for very young or very old. Robotic use. I know we have had vision. Yes, no, must. Can we be dogmatic? We had a dogmatic talk. I am also from that same.
Real advantage with the robot, definitely have. But
Okay.
having said
Arun?
that, yes, it can be done, conventional also.
Yeah, it can be done, but robotic real advantage? Arun, what do you
Robotic
think?
whenever possible.
Whenever possible.
Yeah,
Okay.
whenever possible.
Dr. Mohanty, robotic?
Robotics uni has definitely has got a better outcome compared to use of robot in total knee. So always preferable to do robotic.
I think uni has to be robotic. I don't think non-robotic should have, because it's very surgeon-dependent surgery. There are a lot of technical issues which can happen during operation, which has a big bearing.
Dr. Mohan?
Yes, sir. Robotics has a very important role, and as per when we are discussing about the size, when we in the planning stage itself, we could understand the size of the tibia. If you use a robotics, then we can decide whether to continue with uni or you can convert into TKR.
Great. So we have a consensus of the entire panel that the robotic is the way forward. Okay. So quickly, one key point, one or a complication that one should avoid. What's your favorite one point, each of you? It's a learning session, so we would want one pearl from each of you.
Tibial fracture.
What should you do to avoid tibial fracture?
The cut has to be very, very
So robotic,
clear. That-
non-robotic?
Yeah, you should not go deep.
Deep. Arun, your one favorite point that you would want people to go here from
Yeah,
learning.
avoid undersizing the tibia. 1 or 2 millimeters overhang is fine in a uni.
Undersizing the tibia. Great. Dr. Mohanty.
Agree with Raj. Tibial fracture should not tilt your saw blade, so that posteriorly, which are not able to see, that should be fracture.
Anything on femoral side, sir?
Look at, well, tibial side, you should look at the quality of the bone. If you have any doubt about bone is little osteoporotic, I don't think you should do uni, because risk of.
The most common error is over release. Like, so when during exposure, like we should make sure that we should not do a release of the deeper MCL, and don't try to remove all the osteophytes and injure the deeper MCL. Then
Okay.
it will valgize.
So I think two key points. Tibial cut is the foundation. It has to be right. Avoid fractures, avoid over-release. Correct. Okay. How do we assess our post-op X-ray? It's good, bad, ugly. You think it's a good X-ray, bad X-ray? Dr. Raj.
Again, as we do it in the pre-op, the proper weight-bearing alignment X-ray, varus valgus stress view also helps. That helps whenever unexplained pain.
No, this is a normal post-op day one portable X-ray. You are happy with the X-ray? You think you do it differently?
This should be okay for
Okay.
immediate post-op.
Immediate post-op. Arun?
It looks good.
So what do you look at the X-ray? Just quickly for everyone's benefit.
Yeah, I think apart from what we look at in terms of alignment in general TKR, we have to look at the joint line restoration as compared to the lateral side. That is
So
one
joint
thing.
line restoration, tibial slope,
Tibial slope
tibial
and
cut.
coverage. Yeah. These are
femoral
nicely
side,
covered.
anything? Quickly, we are
Also, how much medialized or lateralized?
no overhangs. Okay. Anything else? Any new points?
It should be overall undercorrected. It should be varus or maximum go on to neutral.
Okay. Quickly, we are just having one more minute. So lateral uni, will you do it?
No, not it.
Yes? No? 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 Anyone yes? So no. One key tip. So we've skipped that.
What is your take on lateral uni?
Yeah. So I think yes. The only challenge.
The indication for everybody, even for us.
So anyone who is below 50 years of age, for me, has got isolated lateral compartment thing and has got good ligamentous stability. These are the three indications. And I would be doing it regularly. So the surgeon indication and a patient indication. So a surgeon who is doing it regularly, he gets a right indicated case, he should be doing it. Unfortunately, it is a cat and mouse thing. Because you don't do enough, you're not good at it.
Oh, regularly means how many per year or
So-
how many per month at least?
So I think both, so at least you should be doing 10 medial unis a month and at least 1 or 2 lateral unis a month. Because you cannot expect to do 10 lateral unis. It will be unnatural for most people here. Okay, so just one. What went wrong and what now? Just last question and we end it.
Yeah, I think probably a posterior cut gone wrong is something that you could suspect. I mean, the sagittal cut could have gone wrong. It seems to be posteriorly displaced fracture. Yeah, again, hammering and all that things, but generally it is a sagittal cut that goes wrong. Or the other thing is when you put the tibial component, the tibial jig, if you make too many pinhole tracks, that is also known to predispose to this fracture. So the sagittal cut and number of pins.
Okay, we end it here.
Thank you
very
all
much.
for this wonderful discussion. Thanks a lot, Dr. Vaibhav and other panel members. There's a lot of take-home message for the audience. Thank you.